This conference will now be recorded.
So today we'll be discussing about hypertensive retinopathy. Last time we talked about diabetic retinopathy. In fact, if you sit in the OPD, many times we get equal number of hypertensive patients because there are a lot of patients with hypertensive retinopathy. But it's not as dangerous, always as dangerous as a diabetic retinopathy, as we associate more blindness incidents with diabetic retinopathy. But hypertension, because it affects such a large population, is important to us. So today we'll discuss about hypertensive retinopathy, how it affects, and how we can classify, or what is the management part in short. So hypertension is known as a silent killer. It affects more than 1 billion people in the world. The incidence is slightly more in males, 1:4 ratio versus 1:5 in females. And unfortunately, 2/3 of these patients come from low and middle income countries. And there was a study done 25 years back in the same village, and so that in the same village, there was a 3-fold increase in number of hypertensive patients. So the hypertension is actually increasing rapidly over in our scenario also, as well as worldwide. And it's called a silent killer is because many of the patients don't know they have hypertension. So by definition is systolic more than 140 and diastolic more than 90 is defined as hypertension. This definition may vary according to different classification, but most of the time we follow these norms. So any the systolic or the diastolic or both are elevated, then it is labeled as hypertension. So most of the hypertension, more than 90%, is called essential hypertension. That is, it's a primary. You will not find a secondary cause in the body if you examine the patient. Only in 5 to 10% you will find a secondary cause. So when we don't know the etiology, as we know, we always talk in terms of risk factors. So what are the risk factors? We have modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors, risk factors we cannot do anything about, like family history. So if your family member is hypertensive, there is some risk that you will also get hypertension. Likewise, age is also non-modifiable risk factor. As you are older than 65 years, the chance of getting hypertension increases. Likewise, if you have other comorbid condition, like if you're diabetic or you have some kidney disease, also the chances of hypertension will increase. But there are also a lot of modifiable risk factors, like excessive salt intake, high saturated and trans fat intake, if you are taking very low amount of fruit and vegetables intake, associate if you're a smoker, if you're an alcoholic, if you're an obese person, and if physical inactivity is less. If you see, most of this modifiable risk factor is actually a lifestyle related risk factor that is actually increasing because of urbanization. So prevention is basically tackling the modifiable risk factors. So according to WHO, if you want to reduce the chances of hypertension, so reduce the amount of salt intake. It should be less than 5 grams per day. I think in Nepalese, an average take around 10 grams or so. And also eating more fruit and vegetables, being more physically active, like exercise, or adopting a more healthy kind of lifestyle. Avoid tobacco. Alcohol consumption is also bad. If you're alcoholic, you have a higher chance of getting hypertension. And limit the intake of foods in high saturated fats. So saturated fats mainly animal fats, also trans fats, and trans fats is present in a lot of fast food that you eat, like pizza, burgers, or cookies, and everything that's made, or in also like factory made products, food products also are rich in trans fat. So it makes your food tasty, but in the long run it will cause you to be a risk factor of hypertension. So we need to adopt these factors to make sure that the risk of getting hypertension is less. So WHO also says the heart technical. This is what Nepal has also assigned for hearts. It's just short form to prevent hypertension and manage it. Adopt a healthy lifestyle with counseling to the people in community, evidence-based treatment, access to essential medicine and technology, team-based care, and systems for monitoring. So when we talk about pathogenesis in terms of pathogenesis of retinopathy, we talk about two things. We can divide it into like vasoconstriction, sclerosis, and exudation is one way of explaining, and this explains most of the retinal findings. That is one of the retinopathy. And hypertension not only affects the retina, it also affects the choroid and optic nerve also. So we have retinopathy, choroidopathy, and optic neuropathy as well. So what happens in the vasoconstricting phase? So as you know, we have the small vessels and have this mechanism what is called autoregulation. And autoregulation is the method by which locally they control the amount of blood that is flowing through. So likewise, if a tissue requires more oxygen or more blood to flow, then it will dilate. Likewise, if it wants to less amount of blood flow to occur in that area, then it will constrict to make the amount of blood flow less. So vasoconstrict phase actually is related to autoregulation. When the blood pressure goes high, it means much of the flow in the blood vessels is more. So the body counters this by causing using the autoregulation, that is to decrease the amount of blood flow. So this is by generalized or focal narrowing of the vessels. So this is not seen in the vein, it's actually seen in the arteries. You can see there's a focal narrowing, or there may be generalized narrowing, which occurs due to autoregulation as a response of increased retinal vessel pressure. What we see in the sclerotic phase is over a long period of time, when the hypertension, what it causes is the sclerosis. Sclerosis is basically hardening of the vessels. So if you see, sometimes it happens also with age. If you feel the vessels of an old patient and the young people, you can see in the older patient, the vessel is quite thick and rigid. Actually, you can roll it. So this is called sclerosis, and this happens because of the thickening and hyperplasia of the walls, also some degeneration occurring. And the sclerosis again is seen in the vessels. So when the arteries become sclerosed, that is thickened and hardened, wherever they cross the vein on top of it. So let's say there's a vein underneath, and the artery is, as you can see in the picture, it is going over the vein, and because this artery is now hardened because of hypertension, then it presses on the vein, and this leads to what we see clinically as AV nipping. Also, the other thing you see is the reflex. Artery reflex is what you see. You can see a thin narrow line of the light that is reflected from the ophthalmoscope or the examining device. So there is also change in the reflex, or in the later stage we'll see about copper wiring, silver wiring. This is all associated with the sclerosis of the vessels. And the final is when this, because of prolonged or very high blood pressure, we find the exudative phase, which is the breakdown of the blood ocular barrier. And this is because the vessels are damaged and there's exudation of contents in the vessel, that is the blood, lipids, and also you can see it as a retinal ischemia. You can also see some hemorrhages, cotton spots, optic disc edema. So you can see in this picture, it's all we're seeing this. You can see elevated blurred optic disc, lots of retinal hemorrhages, exudation, cotton spot. And you see in hypertensive retinopathy, these signs are centered around the optic disc. If you see a patient of diabetes, or even a vein occlusion, then you will see these hemorrhages in the far periphery also. But in the hypertension, if you see, it will be centered around the optic disc. So this is one way of finding out what is the cause of the edema. Likewise, this is the signs we talked about, what we see in the retina. But as we talk, there's also choroidopathy. So in choroidopathy, there are a few signs. As you know, choroid is slightly difficult for us to examine because the RP, we don't see the choroid very well. But there are some signs of choroidopathy. These are like Elsning spots. You can see this black pigmented spots. This is focal area, some RP hypertrophy, and this is surrounding small halos. So in the early phase, if you see these areas, it'll be a slightly brightly illuminated, or would be like a yellow dots, and later on they develop pigmentation. So this is mostly seen in the mid periphery. If you go slightly more periphery, what you see is a cygrus streak, and this is basically the damage to the choroidal vessel that causes like streak-like atrophy of the RPs later on. This also become pigmented later on. So what happens with the hypertension in the choroid, there's a vasospasm, and there's also compromise of blood supply. And as we know, the RP gets the blood supply from the choroid, and because of this severe vasospasm, what it causes is the RP loses part of its nutrition in focal areas, and it undergoes atrophy, or some areas, some hypertrophy, and this gives rise to these signs called Elsning spot and cygrus streaks. You can see this is also cygrus streak. These are large placoid lesions in the periphery. So these signs denote that this patient has undergone very high. Usually it happens in the malignant hypertension, and that the patient has developed hypertensive choroidopathy. And the other part is the optic neuropathy. We talked a bit early also. Again, the same thing. We talk about blurred and elevated disc margin, lots of hemorrhage, exudation, and all these signs are centered around the optic disc. Likewise, in this phase, you can see there are less hemorrhages. Probably this optic disc edema due to hypertension is slightly older, so not what hemorrhages now, but still you can see the disc edema is present. So retinopathy, choroidopathy, and optic neuropathy. These are the three areas that it affects the hypertension affects the eye. So let's go to the classification. So you can see in the classification, I've shown you a picture with a person seeing with a direct ophthalmoscope. And if you see actually the hypertensive, the classification of hypertension was actually done with an ophthalmoscope, especially with a direct ophthalmoscope. So many a times in OPD, we're using actually to 20 diopter in the indirect ophthalmoscope, or maybe 90 diopter in the slit lamp. But actually, if you want to see the subtle changes in hypertension, the best way to see is with a direct ophthalmoscope. And this is the findings based on the direct ophthalmoscope that is being used to classify hypertension. So the early, if you even dates back to 19th century, Liebach and Marcus, actually they reported first about hypertensive retinopathy. With very limited devices, they were able to talk about hypertensive retinopathy. The Sheets classification was first, it was seen in 1953, and then he has two hypertensive changes that said. One is based on the light reflex, and the other is changes in the vessel. So this is the changes in the vessel. Stage 0 is no changes. In stage 1, you have diffuse arterial narrowing, as we talked about. This is due to autoregulation, due to the autoregulation leading to the focal spasm. Those diffuse arterial narrowing with no focal constriction. In stage 2, you have more pronounced arterial narrowing with focal area of constriction. Stage 3, you have focal and diffuse narrowing with retinal hemorrhages. And stage 4 is the last stage where you have retinal edema, hard exudate, and optic disc edema. So let's talk about a few of the signs we are talking about. So you can see, again, we talked about this is the artery going on top of the vein. You can see the vein is underneath, and you can see the vein flows very straight. There is no change in the caliber. There's no change in the direction of the veins. But there are some signs like gun signs. So as you talked about the sclerotic phase, over a period of time, the vessels become hardened, and when they cross over, they start pressing on the vein. So you can see this is a gun sign. What the artery has done is actually compress the vein, and because of the same vein, you can see the vein is kind of a tapering pattern in the both sides. So the vessel in this area, the vessel is not able to flow nicely, and so therefore we see this tapering effect. So this is known as gun sign. The other sign is called Salu sign. Here you can see what we talked about. You can see in the vein it flows very straight. There is no change or deflection. But here you can see the vein came here, but there is slight deflection. So this is known as Salu sign. That is, and this happens if you see a gun sign happens more when the artery crosses the vein at 90 degrees or close to 90 degrees. But many a times it's actually angulated. So when it's angulated, it not only compresses but actually pushes the vein to the side, especially at the crossing area where they share the same sheath. So hence, if there is some deflection of the vein, then this is called a Salu sign. And sometimes compression doesn't cause accumulation of blood in both sides, but distal to the compression, you can see accumulation of blood, so that the caliber of the vein has changed. So compared to the proximal, the distal part is more dilated because the artery has compressed, and now the venous blood flow is not able to flow freely. So there is some accumulation of the blood here, making the size slightly more bigger or more caliber more thicker than this side. So this is known as Bonnet sign. So these are some of the signs we see at the areas of AV crossing. And when you examine the fundus of the patient, usually we see in the arcades, the superior temporal and superior nasal, not in the nasal side. The nasal quadrant, the vessels actually radiate from the optic nerve, so they don't cross that much each other. But in the arcades, because the arteries and veins cross each other, this is where you can see these compression signs. And as we talked about, the best way to see it with the direct ophthalmoscope, the best way to see it with the direct ophthalmoscope, because it gives you a very good magnified image. So again, the same thing you can see in this picture. You can see the vein. This tapering of the vein both sides because of the arteries crossing. This is the gun sign. Here there's a slightly deflection of the vein with this sclerosed artery, is known as Salu sign. The other part is the change in the reflex. So normally when you see with the direct ophthalmoscope, light shines on these arteries. The vein is slightly darker, but the arteries actually reflect the amount of light. And this reflection is because of the vessel, and as well as because of the blood flow that is flowing into the vessels. So both factors play a role in giving this light reflex. So as the hypertension retinopathy takes place, and we talked about this sclerosis of the vessels, and because of the sclerosis, there is a broadening of the light reflex. That means the light reflex that was a small streak now appears more broadened. So this is a grade 1. We have broadening of light reflex with minimal AV crossing. This is actually the Sheets classification based on the AV crossing and light reflex. Grade 2 is the light reflex changes and crossing changes are more prominent. In grade 3, the amount of, because of the sclerosis, slowly the vessels, the caliber goes small and small. So the amount of blood flow becomes less. So the light reflex becomes broader, but also becomes more dull. So by grade 3, it becomes very dull. So you see a typical what is known as a copper wire appearance. It appears like a copper wire. And in grade 4, which is final phase, there is very limited or no flow in the vessels, and as you have this white appearance, which is also defined as a silver wire appearance. So you can see in this picture, this is a normal artery and vein. This is the small light reflex we talked about. And if you go to grade 1, you can see it's now become more thicker. So there is a broadening of the light reflex. There is no AV crossing changes over here. In grade 2, you can see it becomes more prominent. There's a light reflex more broader, and then you can see some nipping also. AV changes is there. In grade 3, now it's become slightly dull, so it has this typical copper wire appearance, and you can see in grade 4 it's completely scleral vessels. So this is hypertensive retinopathy based on the arterial light reflex and crossing. So these are both classification given by Shees, and we sometimes use also many times the modified Shees classification was just combining this both classification and making it much more easier. Like grade 1, no changes. Grade 1, there is very detectable arterial narrowing. Grade 2, obvious arterial narrowing with focal irregularities. Grade 3 is grade 2 plus some hemorrhages and exudates, and grade 4 is obviously when there is all these changes plus optic disc edema. So most of the classification we are using now actually is the Keith Wagner and Barker classification. What Keith Wagner and Barker did was they not only talked about the different signs that we see in the retina, but they also added the systemic parts also. And the purpose of this classification was to associate with things with not only with retina, what is seen in the optic nerve, but with the clinical signs, systemic clinical signs also, and also long-term morbidity and mortality. So in grade 1, he has got, it's quite similar to Shees, but slightly changes, light narrowing, sclerosis, tortuosity is there, and the patient has mild asymptomatic hypertension. So grade 2, again, definite narrowing, focal constriction, sclerosis, and blood pressure is much more higher and sustained. Likewise, in grade 3, you have cortical spot, hemorrhages are there, and also in systemic, they may have patient have headache, vertigo, blood pressure is much more higher, nervousness, mild impairment like cardiac, cerebral, or renal. And grade 4, you have neuroretinal or optic disc edema leading to papilledema. And here you see signs like Sigrid spot, ethnic spot that we talked about due to choroidopathy, blood pressure is persistently high, elevated in patients. There's headache, asthenia, loss of weight, and dyspnea, and many other systemic complications. So most of the time, the classification we are using is Keith Wagner Barker classification. But what we have done when you use this classification in OPD is to narrow it down. So we are only talking about the retinal changes now, and not about the systemic part of the classification. So let's see the classification, the same classification based on only on the retinal findings. So it's very simple. Grade 1, look for this arterial narrowing. There may be slight broadening of the artery reflex, but there is no AV crossing signs. In grade 2, you have AV crossing, focal area of spasm you may see in areas, but there is AV crossing signs. You can see there is tapering of the vessels over here. Likewise, same, you can see the continuity is broken over here. You can see this. So this is Salu sign. This is a typical bonnet sign. Sorry, this is just sorry, not this. This is the Salu sign. And grade 3, only grade 3 we will have bonnet sign. So in grade 3, there's change in reflex also. Typical, we have a slightly more reddish hue, that's copper wiring is there, and then we have this much more severe AV crossing signs like bonnet sign is there, also some gun sign also there, right angle deflation, and basically we define grade 3 hypertensive in terms of cotton wool spots, hard exudates, and hemorrhages. And final is the grade 4 hypertensive retinopathy when you have all these changes as well as single wiring and optic disc edema. So, but if you have a grade 4 hypertensive retinopathy, your survival 3-year survival rate is only 6%. Whereas if the patient has a grade 1 hypertensive retinopathy, then survival rate is more than 70%. So there's some newer classification also, which is again modification of the Keith Wagner various classification, like Michel Wong, which is a simplification. And the purpose of this classification, if you see grade 1 and grade 2, if you're talking about grade 1, we are just talking about just spasm of the vessels, whereas grade 2, we are talking about AV nicking signs. So these signs are not always so easy to analyze. There may be interpersonal variation also. So what they have done is, instead of grading grade 1 and grade 2, they have put it into one single grade. That is, grade 1 is mild retinopathy, which consists both of arterial narrowing, AV nipping, and all these AV changes. Whereas grade 2, they have put moderate retinopathy, and then you see hemorrhages, microaneurysm, cotton wool spots, or hard exudate. And grade 3 is the hypertensive myelin hyperretinopathy, where you have moderate retinopathy with optic disc edema. So they have actually simplified it, merged grade 1 and 2 to make a single, that is grade 1 or mild retinopathy, moderate, and 2 is when you have hemorrhage, and 3 is when you have optic disc edema. So this is much easier classification, but usually we are following the Keith Wagner classification. The same thing we can see here, mild. In the mild, you have AV changes, some copper wiring changes, copper and then in moderate you have a lot of hemorrhages, cotton spots are there, and in severe then you have the final optic disc edema. But mostly in OPD we are using the Keith-Wagner classification. So how do you approach this patient with hypertensive retinopathy? One is, we talked about age of the patient. Age of the patient is also important, not only in terms of the risk factor of the patient, but what the AV crossing signs we talked about. Sclerosis of vessels, as I talked earlier, is not only due to hypertension. It can also happen due to age of the patient. So many a times you may actually encounter a patient where you see an AV crossing sign, you think it's hypertension, but when you take the history, then there is no history of hypertension. So maybe in these cases, it could be a pure case where there is no hypertension only due to the age factor. There is sclerosis of the vessels that has caused the AV nipping, or maybe this patient has latent hypertension or undiagnosed hypertension, which is not we are not able to diagnose at the moment we are examining the patient. So, and also, if you see the age of the patient, once you have the sclerosis of the vessel, which occurs with age, the chances of having these lots of hemorrhages are much less. So if you see a young patient, especially in teaching hospital, we get a lot of young patients who develop kidney disease, and they have very high blood pressure, like 180 by 110 or 200 by 100, very high blood pressure. In this patient, if you see the fundus, then you see a lot of hemorrhages because the vessels are not hardened and the hypertensive signs are seen much easier. But sometimes, with the same blood pressure, if you see an older patient, and because the vessel wall is much more sclerosed, so many of the signs are masked. Actually, you may not see a lot of signs in this patient as compared to a younger patient. So age also takes a factor when you are examining the patient, especially for the risk factor of hypertension, as well as the clinical signs will vary. They are more severe hypertensive signs clinically will be seen in a younger patient compared to an older patient. The other factor is duration. Is also, we can also classify a lot of hypertension changes in acute and chronic changes. Most of the changes we talked about is actually chronic changes. In acute changes, the first sign is actually vasospasm is the first sign that happens in acute phase. By the time the patient comes to you, many a time the hypertension has been there for long duration, and actually what you're seeing is the sign of chronic hypertension. So other factor is also control of blood pressure. You have to see whether the patient has been controlled, whether the patient is admitted in ward. You can just read the chart and see what is the blood pressure. Also the past history of the patient, how you can see the old prescription, how the blood pressure has been maintained, whether there's a sudden elevated spike of the hypertension within a few months. And many a times these signs take, like if the patient has grade 3 or grade 4 hypertensive retinopathy, the hemorrhages and exudates take at least 3 to 4 months to resolve. So if you see these signs, then you can presume that the blood pressure was spiked maybe around a few months close to the time. Also systemic disease, as we talked about, 5 to 10% will have a systemic cause. So we have to look for systemic diseases to find what the cause of hypertension is. And so in this case, where the hypertension is caused due to systemic disease, the hypertension is labeled as secondary, not primary. So primary, what we talked earlier, was due to hypertension when there is no cause known, whereas secondary, as we talked, like renal, patient may have renal or some endocrinal diseases that leads to hypertension. Also some systemic diseases will worsen the retinopathy also. So we talked last time also, with diabetes and hypertension, they go hand in hand and they may worsen the condition of the patient. And treatment history is also important, the type of treatment the patient is getting, like the patient on dialysis or many factors, or the type of drugs they're taking, how many drugs it required to control the hypertension. If let's say the patient is using a lot of drugs, that means the blood pressure is not so easy to control, and maybe there were spikes of increase in between. Likewise in dialysis, we have noticed in patient with renal, undergoing renal dialysis, the blood pressure actually fluctuates a lot when they are undergoing this dialysis. So in this patient also, you may see a lot of signs associated. Even though the blood pressure is shown to be normal, the blood pressure may be varying when the patient is undergoing dialysis, as a result of which the patient is developing this retinopathy. So examination is nothing new. We do just the regular vision, best corrective vision, intraocular pressure. Most of the time vision is unaffected. Only in grade 3 and grade 4, when the macula is involved, that you see change in the vision. Otherwise, grade 1 and grade 2, there's no changes due to hypertension per se. Intraocular pressure, sometimes they will develop neovascular glaucoma or venous occlusion. They may be changed in intraocular pressure, or the patient may have a carotid disease because of hypertension. So we need to do a direct fundus examination. But as we talked earlier, most of the signs you see is actually around the arcade and optic disc. So detailed dilated fundus evaluation with more signs. But the other purpose of doing a dilated fundus examination is, as we talk about the complications, some of the patients actually have venous occlusion because of hypertension. So while you're evaluating a patient of dilated fundus evaluation, also look for the complications of hypertension, which is very commonly called venous occlusion. In venous occlusion, around 70% of the venous occlusion is actually attributed to hypertension. So fundus photography is also required. If the patient has grade 3, grade 4 hypertensive retinopathy, you can do a fundus photography ultrasonography to see how the patient is improving when the patient comes in follow-up. FFA is required if you see a lot of ischemia is there, or you are seeing a patient with venous occlusion. Usually we don't do FFA most commonly because a lot of these patients also have renal problems. So FFA is not a treatment of choice. OCT you can do to see RNFL or macula or choroid thickness. This are elevated in the acute phase where there is a lot of edema, but in the chronic phase, when the patient has hypertension, the hypertensive patient, retinopathy for a long duration, or hypertensive choroidopathy for a long duration, actually there is a thinning of this retinal nerve fiber, thinning of the choroid that can be seen. So macula, obviously, if the macula is affected, if you see any signs in the OCT, then obviously you can say the patient also may have loss of vision as a result. So treatment part, like we talked about diabetes, there's not much you can do in hypertension. This is basically a very conservative management. That too, you don't have to do much. It's the physician who will treat the patient. So the main part is the control of the blood pressure that needs to be maintained for a long time. Management macular edema, sometimes we give an avastin or we have even tried intraocular steroids like dexamethasone to control the macular edema. The results improved the edema, but the vision changes were not so much as we expect. But most of the time, we wait conservatively for this patient to resolve and takes some time. But in grade 4 hypertensive retinopathy, they may lose some of the vision. But most of the change is actually quite reversible. So if you have a patient of hypertensive retinopathy, let's say grade 3 hypertensive retinopathy, there's some hemorrhages, exudates. If you see the patient 3-4 months later when the blood pressure is controlled, then actually they do much better. A lot of the hemorrhages and cotton spot disappear, and the patient has good vision. But if the patient has grade 4 hypertensive retinopathy, there is a chance of having some permanent vision loss, and it's associated with systemic morbidities. And as we talked about, it has also associated with mortality. Only 6% of the patient with grade 4 hypertensive retinopathy survive for 3 years or more. So one of the purpose of hypertensive retinopathy is also it tells a lot about the systemic part of the patient. So many times we get this referral from the physician. They want to know what is the status of hypertensive retinopathy, and it will actually help. So if the patient has a lot of the signs, it's probably the hypertension was there for quite a long time. So hypertension not only causes vision loss due to grade 3 or grade 4 hypertensive retinopathy, but there are some other associated complications. In this patient, you can see there's a large focal area of hemorrhages, which is close to this artery. And this is actually the patient has developed macroaneurysm, and the macroaneurysm has actually bled. And because of the bleeding, there's a lot of this hemorrhages there, and you can see a lot of lipid portion in the blood flow, that is a hard exudates that are flown out of the ruptured aneurysm. So in this patient, when the aneurysm is close to the macula, obviously this will cause loss of vision. You may be sometimes confused with the hemorrhages very much with whether the patient has a vein occlusion or a CMVM. But usually we are able to diagnose, and if you see an FFA, then you can see the dye will collect in the area of the aneurysm. So macroaneurysm is more commonly seen in elderly female patients with hypertension rather in males than in males. The another complication of hypertension, we saw in the earlier picture, we saw the optic disc edema that was very much pink and elevated and also very hemorrhagic. But here you can see this is a very pale kind of edema, and this is anterior ischemic optic neuropathy, and this is also very commonly associated with hypertension. So you see elderly male or female patient come to you with a sudden loss of vision, and then when you look for the optic nerve evaluation, you can see a disc edema, but it's a very pale disc edema. Sometimes the edema can be sectoral, and this happens because the blood flow flowing to the optic nerve is compromised. There is closure of these vessels leading to optic nerve ischemia, and you have that. Hence, because of the ischemia, you have this pale kind of edema, and this kind of patient will come to you with a sudden loss of vision. So it's almost like a central arterial occlusion kind of, or central vein occlusion, where you have this sudden loss of vision. Anterior ischemic optic neuropathy, also the patient comes with this sudden loss of vision, that I was okay. In the morning when I woke up, suddenly I saw my vision was deteriorated, or during the afternoon, suddenly while I was seeing, I noticed that my vision was reduced, dramatically reduced. So, but unfortunately, in this ischemic optic neuropathy also, there's no treatment, available treatment. Apart from hypertension, diabetics also develop ischemic optic neuropathy. And so the management is conservative management, but you have to look for the systemic factors and to make sure that the patient controls hypertension, or if the patient is also diabetic, controls the diabetes. And sometimes the patient comes with optic nerve palsy. So this you can see is a patient with a 6 nerve palsy, and this is also associated with hypertension. Usually it occurs in age 40 years above. Apart from 6 nerve, we may also have 3rd nerve palsy. Usually it's a pupil sparing kind of a motor nerve palsies in this patient, like a 3rd or especially in third nerve, and also you can, in this patient, you have a sixth nerve palsy. And these are, in this case also, you if the patient is above 40 years and there's history of hypertension, usually you don't need to do an MRI. They will recover their motility, but it will take 3 or 4 months. Thank you. So if there are any questions. So this topic is not so as much difficult as a diabetic retinopathy, but hypertensive retinopathy is still important, and the main cause is because it also causes venous occlusion, all these complications we talked about. So Neeraj has asked, what is in hypertension? You say narrowing of the vessels and also broadening. Yes, actually, the narrowing of the vessel may not be in all cases, definitely. But if you see a very severe area of severe spasm, then the arterial light reflex will be definitely, I agree, it will be difficult to see. But in the other vessels where there is not a lot of spasm, you can see there's some broadening of arterial light reflex. But usually, if the classification we follow, we are not actually following this arterial light reflex, because these are very subjective things. If talk about it's more broad or normal, these are very subjective signs, so we are usually not following this. But definitely, I agree that if there's narrowing vessels, the arterial light reflex will be difficult to evaluate. So any more? So Mr. Hira has asked, for those referred for us for rule out hypertensive retinopathy, how our approach should be. So it's the same thing I talked about, that examination is same way you examine a diabetic patient, do vision, intraocular pressure, dilated funding examination, grade the hypertensive, and then we send the report to the physician. The physician, as we talked about, is interested to see the grade of hypertensive retinopathy, whether it's grade 2, grade 3, grade 4. It is important for them because it tells them how long the patient may have had hypertension, especially when they're diagnosing the patient for a short time, for the first time. Also, if as a result of blood pressure, where there's a changes like grade 3 or grade 5 hypertensive retinopathy or not. If the patient has grade 3 or grade 4 hypertensive retinopathy, because the good part of the retinal examination is you get to see the vessels directly. In other parts of the body, like in kidney or the cerebral circulation, you cannot see the vessels so easily. So it's a very good advantage for us that we can tell about how this situation may be in other organs also, whether there is any organ damage occurring in other places. So it gives a nice clue to us. Follow for this patient, you don't need to see the patient very, very frequently unless they have grade 3 or grade 4 hypertensive retinopathy. You can ask this patient to come once a year for an annual examination. And also, apart from the classifying the retinopathy in terms of grade, we also need to look for venous occlusion. So usually, if the patient is fine, grade 1, grade 2, ask the patient to come once a year. If the patient has grade 3 and grade 5 hypertensive retinopathy, you need to follow up earlier, maybe around 3 to 4 months. So in next class, we'll be also talking about venous occlusion. So it's an important complication related to hypertensive retinopathy. Yes, there are some systemic, like Hira has again asked, is there any systemic condition whose fundus one of the most common is diabetes also. So diabetic retinopathy, you may actually get confused, especially if the patient was not diagnosed. The patient says, okay, I only have hypertension, then diagnosis. So I talked to you about one thing, see whether to determine whether this is a diabetic retinopathy or hypertensive retinopathy, see the locality of the signs. If the signs are centered around the optic disc, only up to the fovea, closer to this, then these signs are related to hypertension. When they cross over to the periphery or cross the macula to the temporal side, then these signs could be due to hypertensive retinopathy, diabetic retinopathy, or like a vein occlusion could be one. We have other conditions like pustules or pustule-like retinopathy also, when the signs also mimic hypertensive retinopathy. So there is also there you need to take the help of the systemic diagnosis also to make a clear diagnosis. So hypertension doesn't give a very clear sign, or sometimes it kind of mimics others also. So like in diabetes, where you see microaneurysm when you do an FFA, hypertension is not so easy. But based on good systemic evaluation of the patient, the past history, then you have to take these signs and also the systemic fundus finding also to come to a diagnosis. So venous occlusion and diabetic retinopathy are very commonly that kind of confuse you whether this is hypertensive retinopathy or other. And also in venous occlusion, most of the time it's a uniocular disease. So if you see signs in both the eyes, then it's more likely to be hypertension. And if the signs are only in one eye, then it could be a vein occlusion also. So yes, does the highest stage of hypertensive retinopathy require ocular management? So usually management is very conservative. There are no actually clear guidelines or studies that strongly recommend that you should do something for this patient. The main cause of the hypertension, as you know, the high blood pressure has caused a breakdown of the blood ocular barrier. So it will take time to resolve by itself. So we have the only thing what we can do is wait for this signs to resolve. Okay, yes, can happen. Yes, Ayush Chandan has asked, can hypertensive retinopathy be confused with papillophlebitis? Yes, it can be confused, like even vasculitis, or like you mentioned, phlebitis, or sometimes the optic nerve, even diabetic papillopathy can also confuse you with these signs. And again, I talked to you last time that around focus around the optic nerve, and in this cases, definitely the signs are around the optic nerve. So there is no characteristic signs of hypertensive retinopathy that will tell you, okay, this is only hypertension and not anything other. So you need to take the account of the systemic condition of the patient. If you are suspecting an inflammatory cause like in papillophlebitis or other forms of vasculitis, then you look at the vitreous cavity of the patient, if there is any cells in the vitreous cavity or not. If you see cells in the vitreous, then you can think of a more inflammatory condition and probably not hypertension.
So thank you so much, sir. I think there are no more queries.
Okay, okay. So next class we'll have on vein occlusion, maybe next Thursday.
Okay, sir.
Okay.
Okay, sir. Thank you.